Okay, so we're going to start on diabetes. Hooray! Diabetes, we're going to get into a little bit this week. We'll finish it up next week, as well as do some cases for thyroid, steroids, and diabetes next week. This recorded lecture will take more of the time than is allotted for this week. So don't feel like you have to get through all of this week. Some of this will be involved into next week as well. When we're talking about diabetes mellitus, or just diabetes, is what a lot of people just simplify it to, it's going to be primarily characterized as a disease of abnormal carbohydrate metabolism. One of the hallmark features or key features of diabetes is hyperglycemia, or those elevated blood sugar levels. This can occur either to a relative versus an absolute impairment of the insulin secretion. That means that the body either doesn't produce enough insulin, so that's your relative impairment, or stops producing it altogether, your absolute impairment. Additionally, you might also have some peripheral resistance, so resistance in the periphery of the body to the actions of insulin. This is where the body's cells don't respond effectively to the insulin. You've got two main types. You've got type 1 diabetes, which is about 5 to 10% of the diabetics, versus type 2 diabetes, which is about 90 to 90% of all diabetes cases. You're going to have to know the differences or distinctions between type 1 and type 2 to be able to understand which medications are used for each and what the effective management is. Now let's look a little bit closer at type 1 diabetes. The primary issue here is destruction of the pancreatic beta cells. These are going to be crucial for insulin synthesis or creation and release. So if you have destruction of those, typically through an autoimmune process, it's going to lead to that absolute deficiency of insulin in the body. Patients with type 1 diabetes often have these classic symptoms of polyuria, meaning they're urinating a lot, frequent urination, polydipsia, excessive thirst, they're drinking a lot, and fatigue. Additionally, about 25% of patients may initially present, meaning they don't know they have diabetes until they're presenting usually to the emergency room in diabetic ketoacidosis. This can be a serious and life-threatening condition that's arising from that insufficient insulin production in the body. You do usually need to recognize the symptoms of that because it is going to be a very timely intervention and management that is necessary. Then you have type 2 diabetes. The primary issue we have in type 2 is a relative insulin deficiency. This is going to arise usually from a combination of insulin resistance as well as impaired secretion. So you're not synthesizing and secreting enough, and you're having resistance to it. At the time of diagnosis, most patients are actually going to be asymptomatic, which is going to make that early detection somewhat challenging, which is why we screen for it a lot. Some patients may have those same symptoms that the type 1s did with polyuria, polydipsia, nocturia, blurred vision, or weight loss. And in rare cases, a patient may even present with a hyperosmolar hyperglycemic state, which is a condition characterized by extremely high blood sugar levels, um, marked hyperglycemia, severe dehydration, obtundation, meaning they're kind of just out of it and they don't have that ketoacidosis. So type 1, sometimes they present in the diabetic ketoacidosis. Type 2, rarely you might see them present in a hyperosmolar hypoglycemic state. Recognizing these symptoms is also pretty crucial to make sure that you're being able to effectively manage them and prevent any immediate complications. Like how this picture presents type 1 and type 2 diabetes in just a little bit of a different way to understand the pathophysiology behind it. So in type 1 diabetes, there's no insulin key, meaning the sugar can't go into the cell. It can't enter the cell at all. Like there's no key available to unlock the door. In contrast, type 2 diabetes involves a lock and a key scenario where the insulin key is present, but it can't unlock the cell door because of insulin resistance, or the body's inability to effectively use the insulin. So, type 1, you've got a lock, no key. Type 2, you've got a lock and a key, but they don't go to the same door. A lot of this information about the screening tests was on other slides, but this is kind of just a concise version of the slides altogether on diagnosing diabetes. We need to rely on two of the same test on separate days or two positive tests at the same time. So either two tests confirming the diagnosis on separate days or two different positive tests on the same day. Your different tests that you could do are your fasting plasma glucose, and a reading of 126 or higher indicates diabetes. Normal levels are going to be below 100. You could do a random plasma glucose test if a patient has a reading over 200, so they're not fasting for this, just any reading over 200, it's going to be an indication of diabetes, but they must also show symptoms like increased thirst, frequent urination, the polydipsia, polyuria. An oral glucose tolerance test involves giving this oral load of glucose. Sometimes it's a little juice drink, sometimes it's something they eat, and a result of 200 milligrams per deciliter or higher 2 hours later suggests diabetes. This is usually reserved just in situations where your fasting plasma glucose or your random plasma glucose are inconclusive. They're on the border, they jump around a bit. You can do this test. It's also something you'll see done quite often in pregnancy to test for gestational diabetes. And then we have our hemoglobin A1C. An A1C level of 6.5% or higher is going to reflect the average blood glucose levels over the previous 2 or 3 months. So sometimes you'll have patients come in and you've gotten one of these and it's like 8%, and the patient's like, oh, I had a big bowl of ice cream last night. That must be why, or oh, I wasn't fasting, and you have to explain to them what this test means. That this test is not a reflection of your Snickers bar you ate beforehand. This is an average blood glucose level over the past 3 months. So it's not something you're going to fix in a day or two either. It's going to take a few weeks to start seeing those numbers drop down. Looking at our treatment overall, what is our goal? What is our aim with treating diabetes? Our primary goal is going to be preventing any of those long-term complications associated with the disease. In order to achieve this, our aim is going to get those glucose levels as close to normal as we possibly can. Typically, we're initiating medications when a patient has an A1C greater than 7.5%. Before that, a lot of times you're going to recommend lifestyle modifications, diet modifications, those sort of things. But if someone's over 7.5%, definitely we got to start them on some sort of medication, anti-hyperglycemic medication. You also want to make sure that they're managing their blood pressure. This is going to be crucial. And for patients with hypertension, as we learned last quarter, ACE inhibitors or ARBs, the angiotensin receptor blockers, are going to be our drugs of choice because they've got those renal protective effects. So diabetics can have renal damage long term. So anything we can do to give any sort of renal protection is great. We also have to focus on their lipid levels. Statins are going to be recommended in order to manage their cholesterol in order to reduce any cardiovascular risks. Statins reduce cardiovascular events in patients with high cholesterol and normal to low cholesterol. As well, you need to make sure you have this big comprehensive approach as far as lifestyle with proper diet, adequate physical activity levels, weight loss or maintenance, smoking cessation, any sort of things lifestyle modifications wise in order to improve their diabetic control as well as reduce the complications. We're going to start off with our oral diabetic medications. All of these are taken orally. We will get into the injectables next week. Like I said, we're going to go through these this week, but not all of this is something we might make it through in our 2-hour block for this week. So whatever you make it through, go on to the next for next week. These are our different overarching classes, then looking at the classes of medications that fall into those, and then also looking at some other type of agents. Some of these are oral, some are injectable, so we'll get into each of these individually throughout the lecture. Starting off with our oral diabetic agents is going to be our metformin. The overarching class of metformin is the biguanides. Metformin is going to be our cornerstone of type 2 diabetic treatment. Within this biguanides class and within these oral medications, the way I like to remember that metformin is a biguanide and is the preferred oral medication a lot of times when you're starting treatment for type 2 diabetes, depending on the level, is that metformin is big, biguanide big, in glucose control, or met for men. It's meant for men, and biguanides are big guys met for men. So those are some of my little phrases that I like to use to remember the class for metformin and biguanides. The primary mechanism of action for metformin is going to be our lowering blood glucose levels and improving glucose tolerance. This is achieved by inhibiting glucose production in the liver, reducing glucose absorption in the gut. If we can't reduce it, we don't get into the body. Or we don't absorb it, it can't get into the body, and sensitizing insulin receptors and targeting tissues. So it's making insulin work better in those tissues. All of this is going to increase glucose uptake. Importantly, metformin does not stimulate insulin release. So if it's not actively driving blood glucose levels down, there's little risk for hypoglycemia when you use it alone. So it's a very safe option for many patients. Again, metformin or biguanide, big guy, metformin. Metformin is going to be our drug of choice for initial therapy in type 2 diabetes. It's preferred due to how effective it is at glycemic control, promotion of some modest weight loss, and very low incidence of causing hypoglycemia in patients. So it's really well tolerated. Typically, you're going to initiate treatment immediately after your type 2 diabetes diagnosis. For dosing with this, we'll typically start with 500 milligrams after your evening meal or with your evening meal. If they tolerate that well, then you'll do it twice a day. So you'll have one with breakfast and then one with dinner. Over time, over a few weeks, you're going to slowly titrate them up to 1,500 to 2,000 milligrams per day. So that might be one in the morning, two in the evening, two in the morning, two in the evening, that sort of thing. This gradual increase or titration to the beneficial dose is going to help minimize side effects. So that's what we're meaning when we say if they tolerate it. We're going to go over the side effects in a second here, but a huge side effect that people complain about all the time when they first start metformin is GI upset and diarrhea. So if they're having that, that's what we're meaning on titrating and tolerance. So that's why you have to do it slowly to minimize those side effects. Now looking at our adverse effects, our side effects, very common, like I said on the last slide, is our GI side effects, including a decreased appetite, nausea, diarrhea. We can often mitigate this or decrease the chance of this through that very slow titration to the maximum dose. Metformin is typically weight neutral. Some of these you see can cause weight gain. So this is typically weight neutral, and it may actually promote a little bit of weight loss. Patients complain sometimes of a metallic taste, which can be due to some vitamin deficiencies. You might see a vitamin B12 deficiency or folic acid deficiency, so they might need to take a supplement for that while they're on metformin. And then the big test question that they love to ask on boards about metformin is the risk of lactic acidosis. So your early signs of this are someone that's on metformin and now they're experiencing hyperventilation, myalgias or muscle pains, malaise, unusual somnolence. They just can't stay awake or you can't wake them up. And the treatment for this is often going to be so severe that you have to do hemodialysis on them. It's essential to note that certain conditions are going to make them more predisposed to developing lactic acidosis. So anybody with these conditions, metformin is going to be contraindicated in them. So that's anyone with renal insufficiency, with that glomerular filtration rate or GFR less than 30, active severe liver disease, if they currently are an active alcohol abuser, so they drink excessive amounts of alcohol, if they have heart failure, or if they have a history of lactic acidosis from any other reason. Now let's move on to our thiazolidinediones. You know, some of these words, they're hard for me to say, so I apologize. But your thiazolidinediones or your glitazones. Most of these end in glitazone. So you've got your pioglitazone, your rosiglitazone, so glitazones. These medications work by reducing glucose levels primarily through decreasing insulin resistance. They're going to activate this peroxisome peripheralator activated receptor gamma, which is that PPAR gamma, and this is going to increase insulin sensitivity. So if we're increasing insulin sensitivity, it's working better to decrease that glucose level. As a result, we see increased glucose uptake into muscle and adipose tissues, which is going to decrease glucose output by the liver and cause enhanced fatty acid uptake. Importantly, it is going to be crucial to remember that these TZDs, that's an easier way to say it, TZDs, are not considered first-line agents for type 2 diabetes because we're going to see here in a second that they have some pretty large side effects. So our TZDs, our glitazones, pioglitazone, rosiglitazone, our common side effects that we might see are some upper respiratory infections and sinusitis, sometimes headaches or muscle aches, myalgias. One of the more concerning side effects for some patients, though, is weight gain, which can occur alongside fluid retention and edema. A lot of the time, the weight gain that they're experiencing is because of that fluid retention and edema. These medications have also been linked, and that I have stars here, to an increased risk of heart failure. So that is one of the big ones that they like to talk about with these medications, is the heart failure risk. Patients also may have an increased risk of fractures, bladder cancer, risk of liver failure that may be so severe that a patient needs a liver transplant. So if they are on TZDs, you do need to monitor their liver function tests during the entirety of their treatment. Now we've got our sulfonylureas. These are going to include your glimepiride, your glipizide, your glyburide. These meds are going to work by stimulating release of insulin from the pancreatic islet cells. They're going to bind to sulfonylurea receptors on the beta cells in the pancreas. This is going to block ATP-sensitive potassium channels, and this action, blocking those potassium channels, is going to cause a depolarization of the cell membrane. This depolarization is then going to cause calcium ions to influx quickly into the cell, which is going to result in insulin release. So these aren't causing increased sensitivity, that sort of thing, to insulin. You're actually causing increased insulin release. So it is important to know, though, it's not going to be very effective if the pancreas isn't making insulin. So in type 1 diabetes, the pancreas isn't making insulin anymore. So you can give these type 1 diabetics this all day. It's not going to create any more insulin. So it's not useful in type 1 diabetes. It's mainly just a type 2 diabetic medication. You're causing insulin release, which is going to help with the blood sugar levels. On to our adverse effects of our glimepiride, glipizide, glyburide, sulfonylureas. A key concern with these medicines is going to be the risk of hypoglycemia. No matter what your blood sugar is at, because you're causing a release of insulin, it can lower your blood sugar levels even more. So even if they're already at normal, it can cause it to drop into a hypoglycemic range. So patients do need to be cautious and monitor their glucose carefully if they're on this. Patients should be cautioned about certain that might cause hypoglycemia to be more likely. This could be after like active exercise, or if they missed a meal, something that may cause hypoglycemia in and of itself, and then they take their medication and you drop your blood sugar even more. So they really need to make sure they're monitoring their sugars. Additionally, weight gain is also a side effect associated with these drugs. So you need to caution your patient on that. And then in the name, sulfon, it's a sulfa type drug. So caution with anyone that does have any sort of sulfa allergies. Anyone who's super sensitive, it can cause an allergic reaction. Next, we've got our meglitinides or your glinides. These are your repaglinide, nataglinide. These medications are going to work pretty similar to your sulfonylureas. They're going to stimulate the pancreas to secrete insulin. Again, they're doing this by binding to that sulfonylurea receptor on the beta cell, block ATP-sensitive potassium channels. This causes that depolarization, which is going to cause calcium influx, which is going to enhance insulin secretion. Similar to the meglitinides, though, if you can't create insulin, you can't secrete insulin. So these are not going to be effective in anyone who does not have that ability, so they will not be effective on someone that is a type 1 diabetic. As well, they're not going to be effective if someone has already failed sulfonylurea treatment, because they're doing pretty much the same thing. Side effects, again, hypoglycemia is a significant risk. no matter what your sugar's at, these will probably drop it even more. So you do want to take these medications about 30 minutes, within 30 minutes of their meal to prevent low blood sugar, because your meal is going to increase your sugar levels. So taking it about within 30 minutes of your meal will help prevent that hypoglycemia from happening. Weight gain, again, is another concern, just like your sulfonylureas. Now on to our dipeptidylpeptidase 4 inhibitors, DPP4, much easier to say than dipeptidylpeptidase 4 inhibitors. These are also known as our gliptins, sitagliptin, linagliptin. Um, Most of the time you will hear people say DPP4. DPP4, it's a peptidase. ACE, remember, is an enzyme. So these medications are working by blocking that enzyme DPP4. That is going to stop the actions of that enzyme, which normally work to degrade incretin hormones like GLP-1 and GIP. So by blocking that enzyme, gliptins are enhancing the actions of these hormones. This is going to lead to, important term here, glucose dependent release of insulin from the pancreas, as well as suppressing postprandial glucagon release. So glucagon, just to remember, increases glucose production in the liver. So we're going to suppress the release of that to stop that glucose production in the liver. This mechanism is going to help increase insulin synthesis from the beta cells, while at the same time decrease glucagon secretion from the alpha cells. Key advantage of the DPP4s, though, is, like I said, that key term, glucose dependent, meaning they're going to help lower blood sugar levels without a significant risk of hypoglycemia. If the blood sugars are already pretty low, these won't work as well, so they're not having that same hypoglycemic risk like your sulfonylureas or your meticlinides. Side effect time. Looking at our side effects of our DPP4 inhibitors, again, our gliptin, sitagliptin, linagliptin. We are looking at some common side effects that we've seen on other medications like these are upper respiratory infections, headaches, severe joint pains, myalgias. You do have a little bit difference in some of the more serious side effects. We've got an increased risk of pancreatitis, hypersensitivity reactions such as anaphylaxis, Stevens-Johnson, or angioedema. Additionally, this is another one that can have a potential for pretty severe liver dysfunction, so we do have to monitor our liver function tests for this medication as well. Our SGLT2 inhibitors, our flozins, gliflozin, our sodium glucose cotransporter 2 inhibitors. We talked about these as part of our 4 pillars of heart failure treatment. Now we're on to where they really have their primary use. So we have these SGLT2 inhibitors. Again, they end in flozin, canagliflozin, dapagliflozin, and empagliflozin. These medications work by inhibiting SGLT2 in the kidneys, which is going to lead to decreased glucose reabsorption. If you're not reabsorbing it in the kidneys, this is going to cause increased urinary glucose excretion, meaning you are peeing out the excessive glucose, which is going to effectively lower your blood glucose levels. This mechanism is going to contribute to some caloric loss, so loss of calories, and can also result in some weight loss. So these are a really great option for diabetes. So this is where we look at some of the side effects that we'll talk about too. The key thing is going to be looking at those increased sugars in the urine. SGLT2s are flozins, are side effects of our flozins. Remember, the flozins are making the urine sugar flozin. So flozin of the sugar into the urine is going to have an increased sugar area in the urine and the genitals, which is where we get these side effects of increased female genital fungal infections, urinary tract infections, increased polyuria. If you're peeing all the time, you might get dehydrated. If you're dehydrated, you might get postural hypotension. Looking at how these meds are working makes you realize these side effects. Bacteria love sugar. They're going to go to the sugar and it can cause fungal infections. It can cause UTIs. This is actively making you excrete more, and water likes to follow that, so you could have increased urination, which again, you're getting rid of the fluids that can lead to dehydration. Not enough fluids in your body. When you stand up, you can get postural hypotension. There's also a risk of fractures, acute kidney injury, and rarely you might see a euglycemic diabetic ketoacidosis, which I will leave to Cam to explain the intricacies of that. So it is something that you do have to monitor for. And I have question marks on this because there has been some talks of links of an increased risk of amputations in these patients, but it's kind of questionable whether it is due to the medication, due to the diabetes and comorbidities. So that's why it's kind of not bolded, question marked, hey, let you know you might hear about this. Some other medications you might see used in diabetes, oral agents not used super commonly, is our alpha glucosidase inhibitor, acarbose. How do I know acarbose is the alpha glucosidase inhibitor? They both start with A, alpha A carbose. So that's how we're looking at that. And then how do I remember the side effects? I'll tell you that one in a minute here. So our alpha glucosidase inhibitor, acarbose, is going to work by delaying carbohydrate absorption in the intestines. They're going to inhibit the alpha glucosidase enzyme. So again, ACE enzyme, they're inhibiting that enzyme, which is going to slow the digestion of complex carbohydrates. If you're slowing that digestion, you're going to have less glucose being produced. Side effects, big side effects that you hear about are flatulence, cramps, GI distension, borborygmies, diarrhea. So with that, how do I know those big side effects people complain about all the time? The way I have it in my head is acarbose is gross because farts are gross. So acarbose is gross, farts are gross. People complain about diarrhea, borborygmies, distension, cramps, flatulence. They just feel bloated and gross when they're on this medication. Other side effects that you have to just be aware of is it can cause an iron deficiency anemia. This is one that can cause hypoglycemia, especially if you're using it in combination with other medications. And then also similar to some of our other agents, it can cause some liver dysfunction or increased LFTs. So you do have to monitor those LFTs as well.